Welcome to the Independent Sage Friday briefing. I'm Dr. Goody Singh, and I'm going to be chairing today's session, which is on a focus close to my heart, the crisis in the NHS. Over the last 2 years, COVID-19 has had a devastating impact on our healthcare system. Already suffering from years of underfunding and staff shortages, the pandemic merely pushed the NHS and its workers to the brink. We've all seen the headlines and news bulletins about the impact this is having on patients, with long waits for emergency services, operations postponed, and delays to cancer treatment, as well as difficulties in securing even basic GP and dentist appointments. But what does this crisis look like from inside the NHS? How much of it is down to COVID-19, and how do we go about addressing it? To help us answer these questions, we're delighted to welcome three special guests today. Raymond Arjus is Professor Emeritus of Occupational and Environmental Medicine at the University of Manchester. Professor Matthew Ngada Kim is a consultant physician in acute and general medicine, and Dr. Rachel Ward, a GP in Oxfordshire. So three different perspectives on the issue. But before we hear from our guests, I'm going to hand over to Dr. Duncan Robertson for a breakdown of the latest figures. Over to you, Duncan.
Thank you very much. So today we're going to be looking at what's happening with COVID data, but also I think I'd spend some time looking at NHS data. So what is actually happening in the NHS. Now, some of this data is from the winter period and is slightly out of date, but hopefully it gives you some idea of some of the pressures that are in the NHS from the data side. So I think the first thing to do is to say that actually some of the data we're getting is starting to be a little bit degraded. So for example, in Northern Ireland, they've made the decision to stop publishing some of their metrics. So if you look at the UKHSA COVID dashboard now, it's the kind of top line figure is England data rather than UK data. So I'm going to be talking just very briefly about variants in terms of what's happening there. And in terms of what's happening with the overall numbers of infections. So the first thing I suppose to think about in terms of what's going on and what may be to come is the growth of variants. And as we can see, we have really three that are increasing quite rapidly at the moment. We've got BA2.12.1, BA4 and BA5. Now, each of those are around 4 or 5% of the number of samples that are sequenced in the UK. So something is happening. Of course, there are relatively low numbers of cases at the moment, but it's really watch this space to see what will happen with variants in the weeks and months to come. So over to the ONS infection survey, and as we all know, this is a representative sample of people in the UK. This is what's happening. So there are, we are overall decreasing in terms of the number of people testing positive for COVID, but still, 1 in 50-ish, 1 in 60. I suppose one thing to note there is what's potentially happening in Scotland, potentially going up, but with all these things, there is a certain amount of uncertainty about those figures. So maybe if we look next week to see what's happening in Scotland, but generally overall numbers of cases are falling. So we've got this situation where number of overall cases is falling, number of the new variants is increasing. So we're at this sort of plateau period and really waiting to see what will happen in the weeks ahead. This is the split according to age in England. So if you look from left to right, it's the weeks from in 2022, and the columns are basically age groups. And we can see really it's kind of plateauing in all age groups. So that's a good sign. But as I say, what happens next, we have to wait and see. I think the other thing to think about is these are the number of people that are being admitted to hospital in terms of who test positive for COVID. And you can see that actually the number of people who are primarily there for COVID reasons is relatively small, but still a significant number. So on to some data about the NHS, as this session is about the NHS, looking at staff sicknesses. So you can see this is really, as I say, some of these metrics are really for the winter period, but you can see sickness is significant And I think this is, interesting to see the kind of patient-facing groups as opposed to non-patient facing groups. So we do have significant numbers of people sick, but this is, as I say, relatively out-of-date information. And this is what was happening in January in terms of the reasons for people being sick, infectious diseases and respiratory problems. Now, of course, what's happened is some of these protections are being reduced, but still sickness is significant. And looking at some performance indicators in terms of what's happening overall within the NHS, I think one of the most striking things is what's happening to ambulance times. So this is splitting ambulance calls into various categories, C1 being the most urgent. And we can see really, from January 21, the number of kind of third and fourth categories are increasing very significantly. But I think what's worth looking at is this category 2, this orange line, which is, these are people who need to get to hospital pretty quickly, but this is really what's happening, what's suffering. I think one thing to say is those category 1 patients are being seen pretty promptly. So this is looking at those the same graph, but focusing on category 1. We can see we are going behind that target, and we are getting behind that target, but not as badly as category 2. And this is looking at category 2 calls. The red line is the target, and you can see over time it's actually quite significant delays from that target in various parts of the country. And we're looking at people waiting more than 4 hours from arrival to admission. And we can see this is going back, 10 years. And we can see that obviously COVID has had a significant impact on that. But we are up to, very high levels of people waiting more than 4 hours. Looking at the decision to admit to hospital admission, similar sort of story there. We're getting, more than 1 in 4 of these latest figures. This is for April, who are waiting more than 4 hours from that decision to admit to actually being admitted. And in terms of making, even longer, waiting 12 hours from decision to admit to admission. So this is from March 22, but very significant increases there. Waiting to start treatment, we have 1 in 9 people waiting to start treatment in March 2022, which is obviously very significant and increased. And looking to the number of people who are waiting longer than 18 weeks to start treatment, and as you can see, this is falling well below that 92% target. And looking at people waiting more than 1 year to start non-emergency treatment, we can see, it had a huge effect at the beginning of COVID and at the most acute periods of COVID, but we still have gone from very low figures before COVID to very high figures during COVID. So these are the sort of pressures going ahead that the NHS is facing. And finally, looking at the number of people waiting for diagnostic tests, we can see, this is increasing as well. So these are all pressures that are building up and increasing in the NHS. But of course, we'll listen in this session to people who are really at the coalface and dealing with this. And one final word. So there we are. So just the summary, the COVID dashboard is now looking at just England in terms of their headline figures. We have these variants around 4 or 5% each of BA4, BA5 and BA2 12.1. We haven't really seen those variants increasing in the ONS COVID infection survey because we've got a fall for BA2 with an increase of BA4, 5 and 2.12.1. So we'll see what happens in the weeks ahead. And finally, we've given you some metrics about what is happening in the NHS. So thank you very much.
Well, thank you for that, Duncan. I'm now going to hand over. Oh. Thank you for that, Duncan. I'm now going to hand over to Dr. Benita Kane and Dr. Helen Salisbury, who will now lead a Q&A session with our guests. Helen.
Thank you very much, Goody. And thank you, Duncan, for those really interesting numbers. And we're going to kind of go from what those numbers to tell us to what it's actually like on the front line. We've got 3 guests today who are going to help us understand the effects that COVID's had on the NHS, because as well as this huge task of treating people with acute COVID and with long COVID, infection control measures have altered profoundly the way that we work and our capacity and the capacity of our systems in the community, in hospitals, and in social care. And of course, NHS staff are patients too, and COVID's had an impact on them and on staffing levels. Our first guest is Professor Matthew Inada-Kim, who's a hospital consultant, and I'm going to hand over to Benita Kane to ask him about his experience and his take on what COVID has done to the NHS.
Benita, you're on mute.
Sorry, thank you. Thank you, Helen. I'm delighted to introduce Professor Matt Inada-Kim, who's an acute medicine consultant at the Royal Hampshire, but also the National Clinical Director for Infection and Deterioration. And I've worked closely with Matt on as he was leading the rollout of the oximetry at home services that kept so many people safe during the COVID pandemic. Matt, thanks for joining us. Now, you're here today in your capacity as a jobbing NHS consultant. You work on the front line. We know COVID admissions at the moment, we've just seen the data, we know they're not putting huge amounts of strain on the NHS. So why do you think it is that the NHS is now struggling so much to deliver both that acute emergency care and also outpatient care, so really for the public to understand how the pandemic has created the situation that we're in with these pressures?
Oh, thank you, Biddy, and thanks everyone. I can only apologise to the general public about the strain and stresses that they're under at the moment, in addition to what the NHS is facing. We would love to deliver a best and one where all the access challenges are fulfilled, but currently we're not in that situation, as we're all painfully aware, and as Duncan's data demonstrates. I think COVID took away a lot of our preventative stuff, our chronic disease management. And good general practice is founded on that. And good general practice in some ways suffered through the pandemic as a result, not in addition to general practice, but specialist care as well, at keeping people well with their chronic conditions, diagnosing them early to ensure they were on optimal management. And the knock-on effect of that has been later presentations with greater acuity and greater severity than we would have expected out of the pandemic. The kind of hidden cost of COVID. We know with chronic comorbidities, and diabetes is a great example, there are 6 or 7 key elements that are important for the monitoring of patients, ones that cannot be done easily via a telemedicine consultation. They need to be done face-to-face. And these are the sorts of, I think, interventions that didn't happen through COVID and have contributed to the increasing acuity and severity of illness. When you add to that, a lot of people staying away from healthcare for that 2-year period, for very good reason, and then suddenly in a glut deciding, I guess the shackles are off, time to seek help for that symptom that's been bothering me for 2 years now. We can see why we're going to get that delayed hit, as we do in motorway traffic with the sudden surges. The impact of all of this, coupled with the desire to get on with elective care on a background of increasing emergency activity, is a perfect storm. And in some ways, you can't do both of them effectively together and easily without a complete sea change across the NHS. And I think what we really need from a sea change perspective is proper collaboration between primary care, secondary care, and all the bits in between to actually develop viable integrated care solutions that allow patients to see healthcare professionals same day where appropriate, where they can seek help urgently for themselves where appropriate, and they're directed and empowered to do so, but that we have an ability to also see urgent patients instantaneously and within the right timeframes within a hospital as well. We need to be greater than our individual silos and work together collectively to develop these solutions. And some of them will be painful to implement. They're not easy. They're a revolution. They're a transformation. But that's what we're after here. That's the only way I see us surviving as a healthcare system over the next 5 to 10 years.
Thank you, Matt. And I think you've explained that brilliantly. And the words perfect storm, I think, resonate with all of us. I think in addition to that, and we'll come on to this with our third guest, Dr. Agius, but we've had a real hit in terms of the workforce as well, haven't we? So we've lost a large number of our workforce through not just death, but chronic illness and burnout and stress. And then on top of that, our workload has gone up. During the pandemic, there was 2 years where all of us consultants had to just cancel our routine care and just go to the front line. And it's just had a cumulative effect, hasn't it? Over 2 years, that's just peaked at this moment in time. I mean, can you relate to that?
Massively. And I think the key thing is kindness, isn't it? To ourselves and the demands, but also I think kindness from the system perspective. We need that tolerance and trust and compassion for each other if we're going to survive this. I also think we need to think about job planning as well in a different way, to create some outlet for very busy frontliners who are doing 150%, rolling their sleeves up and seeing patients. It's not sustainable. And we need a means of actually introducing a slightly different career structure that enables people to stay in the NHS. Because at the moment, that burnout is forcing people out. And what we need almost is a busman's holiday where you're still doing clinical work in a slightly different way, potentially, than rolling your sleeves up at, with doing operations or doing interventions, but potentially also being useful in another clinical way that gives you a slight outlet. And I think that's the way we might sustain our careers going forward, not just for doctors, but the whole multidisciplinary team.
Thank you, Matt. That's been really insightful. So I'll hand back to Helen now to hear more about the challenges in primary care, which has taken a bit of a bashing, I think, at times by the media. Over to you, Helen.
Thank you very much. And I'm going to ask Rachel Ward, who's one of my GP colleagues in Oxfordshire, and who is really very much on the front line, both of GP care, but also of trying to think of solutions to the difficulties that we find ourselves in general practice, which are really quite profound. And I just wanted to start off, Rachel, by asking you, how is COVID still affecting your work in general practice?
Thank you, Helen, and thank you very much for inviting me to speak today. It's a great pleasure. So I think the most important thing to mention to start with is when we think about the strains in general practice, I think we can often look back with rose-tinted glasses and think that pre-COVID things were okay, and actually they weren't. We were already dealing with a system under great stress. We knew that we were short of GPs, and it was very common for people to talk about waiting for several weeks, a month to get a GP appointment. Of course, the way that we deliver care has dramatically changed, and it changed very quickly during COVID. So very quickly, overnight, really, we had to come up with ways of looking after people with COVID, with other acute illnesses, whilst continuing to care for and see our vulnerable patients. And really what's happened is that our practices have almost become buildings of two halves. And that very much still continues for us today. We have a completely separate entrance where we see anybody with any COVID symptoms. Of course, now the vast majority of whom are not testing. And then the rest of our patients are coming in and being seen in a separate area. Now, the other thing that's obviously been quite contentious, gets a lot of discussion, is how we're seeing patients and the amount of patients that we see face to face. NHS England required us at the start of the pandemic to switch to a triage system where patients were spoken to first. And I think that was very important as we got to grip with things. Certainly where I work in Oxfordshire, we now give patients a choice. If they have a non-urgent appointment, they can choose whether that is face-to-face or remote. And it's very interesting, the number of people that are choosing still to have a telephone call rather than coming in, because of our busy schedules, our busy lives, and the fact that that can fit in much more easily. But we are seeing a lot of patients face to face. But the biggest change that I would see that has continued is the huge demand for appointments. So pre-COVID, I remember the day that we received 500 calls into our practice. We have 17,000 patients, and that seemed like a big day, but it's now absolutely normal to receive over 1,000 calls per day into the practice, which equates to 1 in 17 of our patients calling every day, and that equates to each patient calling over 20 times per year. And of course, what we're set up for is 2 to 3 contacts per patient per year. So that just highlights how much we are being swamped. On average in England now, a GP has 46 appointments per day. The recommended safe level is 25 appointments per day, again highlighting the real concern that we have for the demand and the patient safety element. And all of this is on the background of a reducing workforce. We are losing GPs every month. So I would say, in summary, our overall changes have been a different awareness to dealing with acute illness, but an ongoing surge in demand that is very difficult to manage.
Thank you, Rachel. And I just wanted to ask, you said a little bit about there being a general shortage of GPs. And how about in your particular surgery, are you short of GPs? Are you short of other staff? Has COVID impacted the level of staffing that you can offer?
Yeah. So sadly, we have seen a real exodus of staff since COVID. And we're talking receptionists, managers, nurses, healthcare assistants, GPs. And sadly, many of our staff have left the NHS completely. They feel that they cannot deal with the pressure and the stress anymore. And that's devastating. And that makes the services, much more difficult to run. I can honestly say that we are constantly advertising for staff on every level. And overall in the NHS, we know that we have 1,600 fewer GPs in the country than we did in 2015. In the government's last manifesto, they promised 6,000 additional GPs, and we are not hitting that target. We're nowhere closer to that. I'm actually working with the Rebuild GP campaign, trying to have discussions with government about the staffing levels. So it's a real issue. And I think one of the other issues is that we've had significant amount of negative press, negative discussion in Parliament about general practice, focusing on things like percentage of face-to-face appointments, which just doesn't give us the full picture. And I think this negative press has significantly impacted on staff morale, burnout. And I can honestly say that I know many GPs who are quitting the profession. And a devastating figure is that 1 in 4 GPs knows a colleague who has ended their own life. Need I say more with that figure? So when we look at workforce planning and how we look after our experienced doctors, we have a long way to go.
Thank you. Thank you very much, Rachel. I'm going to hand back to Benita now, but I think we'll probably all have some more questions for you later. I'll hand back to Benita now, who's going to introduce our next guest.
Yeah, and thank you to both of you. That was a very sobering conversation, and my heart goes out to all GPs at the moment, because I just know how incredibly hard you're working. So that brings us on to our third guest, who's Raymond Adjus. He's an emeritus professor of occupational and environmental medicine at the University of Manchester, and also co-chair of the BMA Occupational Medicine Committee. So Ray, thank you so much for joining us, more so because I know you're on your holidays at the moment. So we're really honoured to have you giving up your time to speak with the public. So how has the COVID pandemic affected the NHS workforce? And do you see things getting better for those of us who are working on the front line?
Well, the COVID pandemic, everybody would concede, has had a massive effect on the NHS workforce. If we look just at the official health and safety executive statistics, and these are an underestimate, as I'll explain shortly. I mean, they tell us that more healthcare staff died of COVID attributable to their work in the NHS than died in the Piper Alpha disaster, the single biggest industrial disaster since the Health and Safety at Work Act. Similar number of social care workers, that's healthcare workers, have died. And these figures are grossly underestimated for several reasons, which time doesn't permit me to go into. But if you stack them against the compensations that the Department for Health and Social Care has given to the bereaved, those are more than double the ones which appear in the official HSE statistics. So there is that huge underestimate of the burden of deaths. And very approximately for every one such death, there are 100 people who are reported and officially acknowledged in the statistics as having suffered from COVID as a result of their work. And again, for reasons which we can't go into detail now, that is a gross underestimate. So in terms of the acute insult, deaths and injuries, this is massive. The current burden that we're facing now means that we have between 3 and 4% of the NHS workforce who complain of some form of long COVID. Again, we don't have time to go into the definition of this. It can range from fatigue with a good prognosis for recovery through to fatigue with a bad prognosis, through to people with strokes, heart attacks, and other damage which they would not have had it not been for COVID infection. So this is a huge burden. And if you look in terms of what we have just heard now from other colleagues speaking, people who are really at the front line, because I'm retired now, those people experience a lot of this because about 1 million working days per year are currently being lost from the NHS workforce due to long COVID. And when questionnaires have been undertaken, and the BMA published 2 excellent reports last week, I apologize, 2 excellent reports, which you should read. And lots of studies show that between 30 and 50% of the medical workforce, at least, are reporting ill health as a consequence of their work. And similar proportions, because there are lots of different studies with lots of different methods, show a degree of burnout which is of a high score in at least one of the 3 categories of burnout. So we're actually talking about half of the NHS workforce potentially not working on full cylinders, if you see what I mean. And as we've heard, these are people who are going to leave the NHS, or who are not going to render useful service, or who may be at a higher risk to themselves or to their patients. So this is very serious, and we've got to move away from the government attitude of counting deaths and trying to titrate what we do based on how many deaths the tabloids can tolerate, or how many people in the ITU can tolerate. We have to really suppress this virus and continue to do so, because we don't know in the long term how this long COVID is going to affect people's cardiovascular function, mental function, and so on. That's for them as individuals. And in terms of the lack of capacity of the NHS workforce, this is going to be huge. So we need to continue to tackle this seriously, both at the preventive end still. We have to suppress this virus, because all these replications of the virus have the possibility of throwing new mutants at us, and we've got to therefore suppress it to protect healthcare staff. We've got to move away, as I said, from the concept of just counting deaths. Occupational dermatitis doesn't kill you. Occupational deafness doesn't kill you. It makes you miserable. So does long COVID. And then we have to do, as previous speakers have alluded to, a serious effort in making the best out of what these people still have to offer the NHS, to improve their health by rehabilitating back to work, but to accept that in terms of the time that they invest in work and the quality of work that they do, there have to be serious structural adjustments to take that into account. Thank you.
Thank you, Ray. And I think anybody who works in the NHS will completely relate to what you've just said. I've just got a question for you. In terms of the support that's available for NHS staff who are currently struggling with long COVID, do you think it's enough? What more needs to be done?
The support that's available to NHS staff, from what we can see in the BMA, from our contacts and so on, is in some respects analogous to what we had on the preventive standpoint. So on the preventive standpoint, we found a small minority of trusts in the NHS, Cambridge, other places, doing the right things, assessing the risks properly, providing their staff with good ventilation, providing their staff with respirators. The vast majority basically said, we're following IPC guidance, which actually means non-compliance with health and safety law. And what we are seeing in terms of protecting the staff going forward is a similar skewed pattern. By and large, most people say we don't have a serious service that is addressing our needs, both in terms of health and in terms of rehabilitation back to our work, for our sakes and for the sakes of our patients. And then amongst that, there are a few good exemplars here and there whose good practice needs to be replicated, not just by example, but by the government providing the serious resources, the serious structural change, the trained staff from anything from psychology to occupational health and so on, to bring about the rehabilitation back to work of these people in a way which is good for their health and good for the health of their patients. Thank you.
Thank you very much. So huge amount to unpack there. Goody, I'll hand back to you.
Thank you for that. And thank you to our brilliant guests for their quite shocking testimonies. And I want to just reflect a little bit on what we've just heard, because we had Duncan's really fantastic depiction in graph form of what's happening to the patients in this country and what's happening in the NHS on the service user end. But we've also just now heard about 3 different perspectives on just how much of a burden this is now for people within the NHS. And I speak as someone who is on that side of the line. And we heard from Matt about the hidden cost of COVID, and from Rachel about this history of neglect within GP, which means that services are now being swamped. And then Raymond, who tells us about long COVID being responsible for more than 1 million lost days of NHS workforce time. All of this to me is speaking about a system that is failing both patients and professionals alike. And as we have heard multiple times there, what we really need is a fundamental rethinking about how we tackle health in this country, how we tackle public health services, and what we are going to be doing as a nation going forward, because clearly it is not enough to say that the NHS will just mop up further cases of COVID. And we must shift towards thinking about what we do in the longer term. Now, I'm going to take some questions from the public. And our first question comes from Gay Lee, who is a retired nurse and midwife from London. Are you there, Gay?
Yes, I am. Can you hear me all right?
Yes, can hear you perfectly. Okay.
Right, thanks. Yes, I'd just like to put the nursing perspective, and I should also say I have been retired a couple of years, but I'm still active in my union. I'm active in Keep Our NHS Public, and one of the things that concerns me is that COVID has been an absolutely shattering thing for the NHS staff generally. But this is a long-term problem, and it's something that really started with the coalition government, which deliberately did not put enough resources into training staff and has consistently, right up to the Health and Social Care Act just passed, refused any kind of workforce strategy, a costed workforce strategy. And we know it's because the Treasury is not prepared to commit to something which I think is completely fundamental to keeping the NHS going. Staffing is always the kind of bottom line of all the problems that we're seeing, whatever discipline we're talking about. And it's the same for social care as well. So what I'd like to know from the panel, and this is a slightly sort of off the wall suggestion, is that quite independent of your fantastic work on COVID, would it be good to have a kind of session with a lot of key people? I'm thinking of the unions, I'm thinking of NHS providers, and even, dare I suggest it, Jeremy Clark and Simon Stevens, if they'd come, because they are also advocating a proper staffing strategy. And there are so many aspects to this. I mean, it's not just pay, it's about the exacerbation of lack of staff on actually the quality of care. It's about housing, particularly in London, and just generally staffing not being able to afford to work in the NHS anymore. So I'm sorry, I'm going on a bit too long, but basically you get the idea that I think really what we need is some kind of leadership in terms of a workforce strategy. Thanks very much.
Thanks, Gay. That's a brilliant question, and it touches on lots of different issues. I'm going to open that up to our panel. Is there anyone who'd like to come in on that? Yes, Rachel Ward.
Hi, thank you very much for that, Gay, and thank you also for mentioning the nursing perspective, which is obviously also incredibly important when we think of the crisis and our staffing crisis. You're absolutely right that we need to be coming together to discuss this with leaders and with government. And actually, there is a move to be doing some of this, as you say. So I have actually been in meeting with Jeremy Hunt, who has been trying to push for the bill that there is a significant planning of staff workforce. As you rightly say, that was rejected. But we are, as part of the Rebuild General Practice campaign, we are coming together with government. I'm going to be in Westminster in June, inviting as many MPs as possible to come and discuss the issues of workforce planning, of staff crisis in general practice. It will be about general practice, but of course, as we've heard, that applies to all aspects of the NHS. And we really are trying to raise awareness of this and get a plan going forward. Of course, we believe that as GPs, we are very much aware of the staffing crisis, but workforce planning is not really our remit. But we need the government and the Secretary of State to take a hold of that.
Thank you, Rachel. Now I can see that Helen's got her hand up, and so did Matt. Helen, you first.
Okay, I just wanted to echo both Rachel, but also something that Raymond just said earlier, which is if we really want to keep our staff, we need to stop them getting COVID, because long COVID is a really big problem, and we can't just pretend it's not there anymore. And I know SAGE has been disbanded because the government thinks it's all over. It's not all over, and we'll continue to lose staff if we don't take COVID seriously. I know it's a bigger problem than COVID, and Gay, I absolutely get that this is a long-standing failure to commit the resources that are needed to the NHS and the resources that are needed to fund it, and the organisation that is needed to think seriously about what workforce we need going forward. But part of that is also about right now stopping our staff getting COVID, and we're not doing it well enough.
Thank you, Helen. Matt, you are next, and I think Martin also had his hand up, so he'll be after you.
I agree with previous panelists, and I think it is a good question. I think there are two answers to this. Firstly, you get what you pay for, and our percentage GDP spend for healthcare still lags the developing, or the most of the developed world per capita, as I'm sure everyone on this panel and probably the population are aware. Certainly compared to other developed countries around the world. And that reflects in terms of staffing ratios from a nursing, medic perspective, allied healthcare professionals in all areas, hospitals, community interface organizations, ambulance services, you name it. And then I think we also need an honest truth about the opportunity to properly join up NHS with social care. Are we really saying the NHS is failing, or are we saying, and I hate to use the words fail, but are we saying that social care is under the cosh so much that it's not able to deliver the service that is required to enable the NHS to function? And is that a better way and a better argument here going forward, when there are organisations with high percentages of their bed occupancy occupied by medically fit for discharge patients who cannot be discharged because there is a lack of appropriate social care? This is all compounded by COVID that has worsened that divide further. You could argue about investment as well, There is a massive challenge within social care in terms of not only its remuneration funding, the staffing they're in, but the pay. You know, who would do such an important, pivotal job that really involves rolling his sleeves up and working all the hours that the proverbial sends for minimal pay, and in fact, worse pay than one would get for stacking shelves in a supermarket? There are some really important economic questions that need to be answered within this that are far beyond my expertise. But I see the problems, I guess, for the lack of social care and the lack of appropriate funding to do to the service what is required.
That's a brilliant answer, Matt. And since we're talking about social care, I just want to point Gay and the rest of the audience to a report that was produced by Independent Sage last October, which is on this issue about the future of the NHS and social care, which is really on this topic and very relevant. I am now going to go to Professor Martin McKee, who had his hand up. Martin, what did you want to say in response to all this?
Very briefly, I just wanted to put this in a broader international context. As some of you know, I was on the Pan-European Commission on Health and Sustainable Development, and I think we need to look at all of the issues that are feeding into this. You know, we need to really look at the burden of disease in our population that's putting so much pressure on the health service. We have a very high winter mortality in this country that other countries don't have. We've got very high levels of deprivation. When we were in the EU, we had the majority of the most deprived parts of Western Europe were in the UK. But we also need to look, as has been said, at staffing. And there's a particular challenge because of the labour supply problems in the United Kingdom, obviously, since 2016, where a lot of people in social care are now being attracted into areas like retail, into jobs that were not existing in the same way in the past. And I think we need to look at all the other obstacles, like the pension changes for doctors, and also the work from, say, the Magnet Hospital Initiative, which is looking at how to retain nursing staff in particular with much more supportive environments. And then we need to look at how we actually work, which does mean looking at task shifting, looking at how we use technology, how we work in teams in a much better way. But fundamentally, we need to make the arguments for investment in health. They are clear. The arguments are very, very clear that if you invest in health, you get higher economic growth, you get productivity, you get more secure and safer societies. All of those arguments are in our report, but I think, unfortunately, they get overlooked.
Brilliant. Thank you, Martin. Really great summary. Gay, you asked a question that has really set us off. Thank you for your question, but I'm going to move on to other questions because the public have lots of questions, surprisingly, about the NHS. And actually, this next question comes from Twitter. And the question to the panel is, how much has the COVID crisis been used to hide further privatisation of the NHS, either directly or by creating the situation where privatisation will be offered as the only solution to save the NHS? Quite a provocative question there. And again, I'm opening it out to the whole panel. Anyone? Oh, I knew that Professor Anthony Costello would have an answer to this. Okay. Anthony, what do you have to say in response to that?
Yeah, I think it's a very legitimate point. I don't think we should be totally surprised that the COVID pandemic has kind of had such repercussions. You know, if we look at the global inflation situation, it's because of big shifts in the balance between supply and demand and the just-in-time global economy. Likewise, this has been a major, stimulus that has caused lots of ructions. And one would hope, if one had a very good, stable system at the beginning, that gradually that would settle down. But we didn't have a completely stable, as we've heard from these devastating statistics. My two worries are, one, hitting tipping points now. The kind of absences of people, the feelings of GPs, the emotions of lots of people thinking, really, do I want to do this for the rest of my life, can set in train a really dangerous tipping point. But the political one is even more important, because there are people, and we've seen it in the right-wing press especially, who want to hit GPs, who want to slag off the NHS, because ultimately their agenda is to put it back into private ownership. And that will lead to a much less effective system, and it will lead to a lot more inequality. And I think we have to be extremely strong at resisting that. And one of the problems is that is the name of the book Britannia Unchained, that was written by several cabinet ministers about 10 years ago, I think before they even came to office. And they all signed up to the idea that basically the NHS needed to be dismantled and privatized. And we know from other countries what that means in terms of increasing costs and reducing access to poorer people who will get a much worse service. And I just want to finish by saying, to me, general practice is the highest form of medicine. And it is the bedrock of all health services. And it should be a fantastic job for people. And I'm in awe of it. My own GP is amazing. I was in the park the other day and we were talking with 3 people, and all of them said he had saved the life of one of their relatives. And it was, you know, that's the scale of the joy of doing it. But it's an enormously pressurized job. I couldn't do it, and certainly not now. But I'm full of admiration for people, and not just GPs. I mean, nurses and all the other care workers that go on in primary care. It's so important to defend this.
Oh, well said, Anthony. Yes, you couldn't have said it better. Heartfelt thanks from all of us to primary care workers across the country. Martin, I saw your hand waving. It seems like you had a response.
No, I think an awful lot of the debate here, and you know, I've written forwards for KONP books and things in the past, and I'm very sympathetic to many of the arguments, but I think we've focused very much on looking at the NHS as it is at the minute, being privatized so that hospitals and general practices and so on are handed to the private sector. One of my, I'm less convinced about that because as has already been said, as Matt has said, we do spend relatively little on healthcare in the United Kingdom, and it's very difficult to make the sort of profits that you see in the United States when we're spending so much less of a share of what is for us a much lower GDP per capita and a stagnating GDP per capita, because let's face it, this country is going nowhere in terms of economic growth. What worries me more is that the privatization will take place with people going to the private sector for their own care. Because the waiting lists are going to be so long, because the delays are going to be so long. So I think that may be where we're going. And that in part is a consequence of the pandemic directly, because we've already heard the burden of long COVID, the loss of workers and so on and so forth. So I think it may happen perhaps by default.
That's very interesting. But what strikes me as being very interesting within all of this is that, you know, we had that figure of £2 billion being handed over to the private hospital sector, but with very little in return. So you're right to some degree that this is not about actually handing over our services to the private sector, but an ideological shift or literally a shift of money in some cases, I think. If there are no more responses to that question, I'm going to move on. Oh, there is. Helen.
I was going to say, I think we do have to see it very much as an ideological thing. If you just think about what happened in COVID, about the failure to use the services that we had and the experts that we had and the expertise, and we've talked about this lots of times before, about how independent labs were set up when we had that capacity, or we could have built on the capacity we had, on the failure to use the staff we already had who knew how to do contact tracing. All of that was ideologically driven. We have to use the private sector. And sadly, as Martin just said, what I'm seeing in my practice is a growing 2-tier system, that the NHS is so poorly funded that those who can afford to go elsewhere. They still come to our surgery, but at the GP level, but even at some places GP isn't working very well, so people do private GP as well. But when it comes to secondary care, when there are literally year-long waiting lists for an appointment, those who can afford it are going elsewhere. And that's becoming a norm, which absolutely wasn't 10 years ago. 10 years ago, I referred people, I got a letter back within a month or 6 weeks because they'd been seen and they'd been sorted by my secondary care colleagues. What's gone is that capacity, and what really distresses me is this lack of expectation now from some of my patients. They kind of assume that they're not going to get anything decent out of the NHS and they're going to have to go private. And that is awful. And for many of my patients, and I'm sure for most of Rachel's patients, that's not even an option. They're having to settle for that second best. We've gone from a universal service to a threadbare safety net, and it's really not good enough. And yes, I think COVID has been a way of disguising that, or an excuse for that in some senses, and we need to do better.
Yeah, Helen, I think you've hit the nail on the head there. With what COVID has done is has allowed the unthinkable to be thinkable now in this country, where private care might even be on the menu of options for so many patients who I'm sure would rather not be thinking about private care. So I'm going to move on to another question from the public, which actually comes back to points we've made in this discussion already, which is about social care. So the question actually comes from the health writer and commentator Roy Lilly, and he asks, the root cause of many of the NHS's problems is the collapse of social care. So why do you think the government is reluctant to make a substantial intervention here? Now, again, I'm going to open this up to the panel. Is there anyone who wants to come in on this? I'm surprised if no one has something to say on this. Martin, was that a hand or Professor Susan Mickey, maybe you'd like to say something here.
Well, just to say it's not really a scientific question. I mean, I think it has to be answered in political terms and in terms of our government's priorities and their value systems. And those are very different. If you look at the surveys and what people say about their, belief in the NHS and social care, their desires for what they want. And so I think it's incredibly important that neither any of us here nor anybody we're in contact with should be at all fatalistic, because the only reason we've got an NHS is because generations before us fought for it and set it up. So, I think we have to actively campaign and fight, and I think Keep Our NHS Public is doing a great job. That's what Martin was referring to when he said KOMP. And I think those are exactly the kind of bodies that we should be supporting. And that really is a kind of a citizens kind of collective action, and also all of us in whatever ways we have any kind of influence, using it in that direction.
Oh, thank you, Susan. It is interesting, though, and it is important, this idea of us being citizens and speaking about what is a political question, ultimately. So, Dean, you had your hand up. This is Professor Dean Pillay.
Yeah, it's a really important question, is critical to a functioning broader welfare sort of care structure. And I'd like to use this question to ask our guests, actually, that the move of the latest bill through to integrated care systems and integrated care boards, of course, is meant to bring together local authorities, health service, education, and so forth. I mean, from where I sit, and I sit on as a non-exec director on an NHS trust, it's actually it's not going to go there. It's still stuck with reducing amounts of money to regions and then to integrated care systems, and it's hard enough to get the NHS bits, primary care, secondary care, community care together, let alone actually having local authorities and then the sort of the broader social care structure. So my question is from you as sitting there working in this interface, where do you see the potential for these integrated care systems in terms of the broader that broader system? Sorry for taking over a question to a question.
Oh no, it's very, very smoothly done. Okay, Rachel, you first, and then I think Matt had his hand up too.
Thank you. So yeah, I would say in an ideal situation, of course, we would all be linked and working together with the same common goal. But I think you've hit the nail on the head there, that very early on in the planning process, there are problems even organising the NHS part of it. One of my main concerns, and this is what we have seen, for example, in primary care networks, is that the idea is great that, we have local led care, but then what tends to come in is a huge amount of restrictions and requirements that it doesn't then allow us to give tailored care for our geographical area, our population, and tailor it to our demographics and issues. So I think, yes, in theory, the integrated care path is ideal, but I think it would very much require freedom for each geographical area to take ownership and not be restricted by national requirements.
Oh, brilliant, Rachel. Matt, did you want to come in on that question too?
Yeah, I'm a big fan of the integrated care model and ICS model in general, because it actually addresses population need, and I think opens the way for a potential bundled repayment structure that might financially get to the bones of what we are trying to deliver, which is optimal care for the population for each index care episode from cradle to grave. Because what we're thinking about is what needs to be invested in at different stages of a patient's normal, non-pathological life, when they have pathology and when they get disease and illness, and then their recovery, and then how do we keep them well and keep them safe. And it's only by divesting that power, if for want of a better expression, from the centre down to the community level and down to population level that I think we're going to make the impact in terms of population health management and I think good use of funding and money. It also forces oil and water to play nicely together. Hospitals and general practice, community, silos, because this is about the whole pathway and not one silo or one centre. And that's an important consideration going forward if we're really going to meet the demand that is coming down the track and is already here in some ways. We have to have the conversation. We have to look above the parapet and start playing nicely together. And that's what ICSs give us the opportunity. And I don't buy that they haven't got the maturity, because they simply have to have the maturity. There is no choice. There's no 5-year bedding in. We've got to start now.
Thank you, Matt. And Benita, I'm going to take your last comment on this question before moving on.
Just very briefly, I think it's really important as well for us not to forget the other social determinants of health. Lots and lots of other things determine how healthy people are, from where they are born, whether they're born into poverty, whether they have good housing, what sort of education they have, whether they have addiction. And actually, as the NHS on our own, we can't solve all of that without us having a wider focus in terms of prevention.
Brilliantly said, Benita, and I couldn't agree more about the social determinants of health, the wider factors that play into our health. We actually have a question from the panel to our guests. So Dr. Steve Griffin, did you want to ask the question yourself?
Thanks, Goody. So as a non-useful doctor to our NHS colleagues, one of the solutions that's been proposed by government to shorten the waiting times and get through the patients more quickly is to actually drop COVID restrictions and drop the separation of patients and drop the wearing of PPE. And I just wondered what the panel made of that in terms of a long-term solution.
Ray, did your hand come up, or were you just scratching your head?
I can deal with part of the answer to that question, not with all of it, but I'll deal with the bit that's within my comfort zone. To me, this policy or policy suggestion seems to come from somebody who has as a driver, a political dogma and a degree of wishful thinking, not from somebody who has learned from the pandemic. And to me, it flies in the face of good science and good practice. Why? What have we learned from this pandemic, which we knew before, by the way? We didn't need the pandemic to teach us about source control, be it noise, be it radiation, be it infection, be it isocyanate fume, be it quarry mine dust. You isolate people from that source as far as possible if you can't get rid of it together. What about the pathway? You stop people being caught in the pathway of transmission, both staff and other patients. So what's being proposed? That everybody goes in one ginormous mix. So our most susceptible staff and our most susceptible patients, some of whom perhaps can't even gain the benefit from vaccination, which in itself is really quite partial and quite limited, getting exposed to the disease again. This is crazy. And the staff and the patients who, in spite of all these steps at source control and at pathway control, still require protection, would still require respiratory protective equipment and other means like ventilation. These are not restrictions. These are protective measures. This is what the NHS should primarily be about, stopping people getting disease in the first place, not mixing everybody in one huge giant cauldron of survival of the fittest because the fittest thing to survive in all this mess will be the virus, and it'll come back at us and bite us. And if not this one, it'll be another one. These people who are engaging in this are engaging in a very simplistic zero-sum game without understanding the implications of what happens when you drop the control of the source, the pathway, and the reception. The dynamics will turn everything upside down, and we could end up very close to square one, like snakes and ladders.
Ray, that was a brilliant, comprehensive answer to that question. Matt, please respond with something, with a brief comment there.
Very briefly, and I can't top Raymond's phenomenal answer, which I think is spot on, and excellent question, Steve. I guess where I'm coming from is going further than that. What I would love to see happen is a cultural shift across our entire population. I mean, why stop there? Why don't we say the whole of the world's population, to start considering when they get ill or suspected that they may have an upper respiratory tract infection, that they don a mask as part of their action towards protecting society. So the onus is not only on us trying to protect ourselves from illness, but we're protecting others from us when we suspect it. And that level of respect for humanity and our fellow human beings, I think would carry us a long way if we look at the relative rates of infection and outcomes in countries where that is more endemic as behavior compared to the Western world where that is not. And maybe we need to go beyond, I guess, just isolationist from a hospital protection perspective, but actually thinking about society as a whole.
Super, super interesting comment there. Thank you, Matt. I'm going to shift the conversation somewhat to more general questions in relation to what Independent Sage does best. And this question is from Barbara Nairn from Aberdeen. And she asks, will the current pandemic make people more susceptible to other viral infections? Have our immune systems been made weaker, or was the reduced contact responsible for this? And I'm going to go to Professor Danny Altman. Danny, what do you make of that question?
Yeah, I think it's a question we often hear, isn't it? For my taste, I'd be interested to hear what Sheena thinks as well. But for my taste, the kind of simple answer is no. I think the concept of kind of over-weakened immune systems is somewhat overrated. The immune system is quite a complex beast that's constantly responding to millions of things around us. And so sure, at the margins, having been through lockdowns and having had, for example, school kids who've missed a few winters of winter bugs may have impacted their repertoire. But I think in the big scheme of things, this is marginal. So I think we're all good to go, really.
Professor Sheena Cruikshank, sounds like you could come back to that.
I think one of the things that can happen with some infections, like things that cause the common cold, is that your immune system needs a little bit of a reminder just to be able to deal with them efficiently. So what it might mean is that you'll have slightly more cold symptoms while your immune system catches up, just because it's forgotten about them. So that might be one of the perceptions that we're seeing. For some individuals, there might be some long-term consequences of COVID on their immune system. We're still learning about that, but we are seeing some evidence that some people do have persistent changes in their immune system function even a year afterwards. And what we need to do is understand more about what that means for subsequent responses to other infections, and who of the patients end up getting those sort of slightly altered immune system. But generally speaking, absolutely agree with Danny. Our immune system's evolved to deal with a whole host of challenges, and it's pretty good at it.
It is true, though, isn't it true that, in many low-income countries, it's well known that if you get measles, if you don't die from measles, you still have an impact on your immune system, and you're much more prone to getting things like tuberculosis and other things in the following 9 months. So there are some viruses that can flatten you a little bit in regards to, or is that a myth? But certainly the figures I remember, and maybe that's related to malnutrition as well, is that measles has a particularly clobbering effect, and maybe other viruses do the same. Danny?
Yeah, no, I just think you've carried us into much more complex immunological territory in terms of, viruses that really kind of perturb immune subsets and do strange things to your immune system. And, Epstein-Barr virus and CMV are obvious examples. But I think you've carried us into really complex space here, which is maybe, further than the question went in terms of, have we kind of missed out on some immune priming and things?
I think the other thing, just to add to that, is what can happen as well is that you can get particular damage or particular things being set up in a tissue site that then affect how an immune response within that same tissue site can respond to something that happens within a certain time frame. So it won't necessarily be forever, but it will be within a time frame.
Yeah, interesting. Very interesting responses there. Our next question is somewhat related but different, and I hope the panel will have just as interesting answers to this. So the panel has been asked about the new study which has shown that vaccination offers less protection against long COVID than originally expected. And essentially the question is, what are the implications of this? And can vaccines actually be tweaked to make them more effective against long COVID, or is our only option just not to catch it in the first place? Steve, sorry, I was on mute. Steve and then Sheena.
Yeah, I can look have a go at that.
There you go, Danny.
Yeah, I thought, had I frozen or am I okay?
You're okay now.
You're good. You're good, Danny.
Yeah, no, sort of simple answer. So, okay, so I don't know that we had particular expectations. I certainly didn't, about what vaccination would mean for long COVID. My simple hope was that obviously any vaccine that protected against COVID would protect against long COVID, and long COVID would be a thing from the first couple of waves. Long COVID has turned out to be so much more ghastly than we thought in so many ways. And one of those ways is that even in the face of a triple vaccination program and a so-called milder variant like Omicron, long COVID is still absolutely with us. And as we heard last week, 380,000 new long COVID cases just from the Omicron wave. So the answer is, as above, that we need the best possible future defenses against COVID and long COVID, and they go hand in hand. And, we're still in a very tough place.
Thanks, Danny. Sorry, Steve.
That's okay. I mean, I was going to essentially say the same thing as Danny. I mean, the first line of defense there is to stop the short version. So, that is absolutely what we need to do. Vaccines plus all the way. But then, until we understand exactly what causes long COVID, it will be very difficult to, I think the question is, can we tailor vaccines towards that? And obviously preventing initial infection is one thing, but we're talking about a study where people have had a breakthrough infection after vaccination. It doesn't seem to make all that much difference. So if there's a viral component, it's also your immune system. It's potentially other factors as well. Until we really understand that and more research is necessary, it's going to be really hard to stop that. So we must suppress this virus.
I think that's a pretty clear answer from our panel there, isn't it? So I'm going to move on to the next question, which is actually from Denver in Colorado. And the question asks, as mitigations are abandoned, those of us who deemed them necessary are now openly criticized. How are you all personally navigating the scrutiny, criticism of others within your own communities as you attempt to maintain your respected positions? I have a feeling that Susan might want to come in on this. What do you say to that?
Well, a very good question, because, we're all facing it all the time. And in fact, on our own WhatsApp chats, we've been talking about it. Often we're the only person at a meeting or in a shop or on a bus that is wearing a mask, for example. Although I have to say, I'm often not the only person. And I think that, as was said before, the reason these kind of mitigations, when you get on a bus, make sure the windows are opened, wear a mask if you're in an indoor, unventilated place. The reason that we're doing this isn't just to protect ourselves, but also to protect other people. And in the end, to protect society, so that we can, get on and, do what we can to, as was that famous phrase right at the beginning, protect the NHS. So I think the important thing is being clear about why one's doing something. Now, there's something called social norms. That's a jargon term, but it means that we're very influenced by what people around us are doing. And there are a certain group of people who are very happy to wear face masks, for example, if the huge majority are wearing face masks. But when it gets down to a handful, even though in their head they know it's the right thing to do, feel awkward or embarrassed or odd in some way. And many people find that aversive, and it is difficult. I think the only way of countering it is just to keep rehearsing to yourself while you're doing it. And everybody who does it becomes a role model. And so other people will see you doing it. And, so it goes. So I think those people who, are really committed, understand why we're doing it, carry on doing that. I mean, I've just mainly talked about face masks. That's such a visible thing. But there's also the issue about not going into workplaces or seeing friends if you've got any symptoms at all, carrying on if you're going to go and visit vulnerable people, take a lateral flow, and really ensuring as much as possible that socializing is done outdoors, that windows are opened. And this is the sort of thing we can just be doing and saying as we go around our everyday lives. And if we explain it to people as we go around our everyday lives, every little bit helps, and some of the big things that happen in society as a result of, hundreds and thousands and then millions of people doing small things in our everyday lives. So my message would be, don't give up, keep going.
Oh, wonderful, wonderful answer, Susan. And just come back to what Matt said earlier about, all of us just doing what's best for the group as opposed to us, just us as an individual. Steve, I think you wanted to say something.
Yeah, please, just quickly. And there are people on this panel who have far greater expertise in public health than I do. But what strikes me about all of this is that what's happened in terms of COVID and in terms of public health is that they've managed to shift this from a sort of population question to the level of individuals. And, the advice is to do this, the advisory guidance is to do X, Y, and Z. You make your choices, and masks have become a massive token related to this. We don't have that for other forms of public health. We don't have that around driving safely. We don't have that around environmental contaminations or smoking in pubs or anything like that. What's happened here is that safety net that we would normally expect from our government, from our health protection systems has been taken away. And it's left to us to really fend for ourselves. And when we're dealing with something that's still a pandemic and still with us, as Duncan said, the levels of the virus are going down, but 2% prevalence is still pretty high for an infectious disease. It's still with us. It's still causing long COVID, and we're going to get these other variants coming, okay? We need that safety net provided, that guidance, so that we can all be free, because as I think we might discuss in the future, many elements of our population really are not, regardless what happened last July. So I'll leave it there and let other people answer.
No, that's, again, very well said, Steve, about that shift from the population level to the individual in terms of responsibility. And also that there are different groups have different vulnerabilities. Benita, did you have something that you wanted to add to this?
Yeah, well, many of you will know that my daughter has long COVID and therefore she wears an FFP2 mask in school. I don't force her to wear it, but I have educated both of my children about potential risks and what would happen if COVID infection came into the house again, and they choose to wear it. And I'm sure some others look upon that as they're the only ones in their class, but they're quite happy to do it. And when my 9-year-old had her vaccination, someone said to her that week, well, why are you wearing your mask? You've had your vaccine now. And she just rolled her eyes at them and went, oh, you can still get COVID after you've had the vaccine. She's 9 and she gets it. She understands because she's had the education. And I think we could do that more broadly for the population.
I think there's something there about communicating at the level of a 9-year-old, which might actually work in terms of getting the message across. But that's fantastic. Thank you so much. Look, thank you to everybody who has been contributing today. It's all we have time for. And so I'd like to thank our guests for contributing to today's discussion, of course, to our regular panel of brilliant experts. And thank you to all of you who have joined in and have given us your questions. We don't actually have a session on Friday the 3rd of June because it's the bank holiday, but we will be back on Friday the 10th of June. Same time, same place. Stay safe and do keep well.
Bye, everyone. Thank you.